Hello learners, this is Dr. Leah Kaler here. This week we are going to be reviewing the impact of trauma, specifically looking at epigenetics and our ability to change. The field has fully embraced the protocol of the DSM-5, and now we're at the 5TR, which was created by the American Psychiatric Association. Some of the benefits of the DSM-5 is that it does help to streamline, and it does become a universal tool for diagnosis. It helps to identify specific characteristics or criteria for particular diagnoses, and it provides that universality to the field of mental health disorders, diagnosis, and ultimately leading to treatment interventions and various treatment approaches. It also helps to catalog symptoms as a means of diagnosis. The downfall of the DSM is that the disorder is identified as genetic or organic in origin. The DSM-5 does not recognize traumatic events or situations that have been environmental or learned as a predisposition towards a disorder. By assigning a genetic cause, we naturally imagine our sickness to be part of who we are. At times, you will see people start to become their diagnosis, and their diagnosis becomes completely encompassing to their well-being. It decreases incentive to change or to explore other root causes. When we identify with a label, this can be very destructive. Since the turn of the 20th century, we've believed in genetic causes of diagnoses, a theory called genetic determinism. In a sense, this has created learned helplessness in the field, and we need to find ways to be strength-based, to empower people, to transform, and to look at opportunities for change. Once we see beyond the narrative that genetics are destiny, we can take ownership of our health. We no longer need to accept the narrative of faulty genes as our fate. Emerging science tells us that genes we inherit aren't fixed, that they are influenced by environment, beginning at the same time in utero and continuing throughout the lifespan. Recently, the groundbreaking discovery of epigenetics tells a new story about our ability to change. This is a paradigm shift from the disease management model to recognizing how our daily environment impacts our health. In fact, this is identified as a new biology, and biologist Dr. Bruce Lipton has done years of research on epigenetics, and he identifies this as an influence for new biology and the power to transform and to change. Genetic expression and repression are influenced by our lived experience and is the key concept here for epigenetics. So therefore, epigenetics says that the genetic code alone is not enough to describe what is happening. We must be looking at cultural and environmental effects on one's DNA. People diagnosed with post-traumatic stress disorder do, in fact, have genetic changes in their DNA. Research has also found that there is a dramatic difference between the immune system genes and brain cell growth of people with PTSD compared to those who do not have PTSD. The science of epigenetics has shifted us away from the disease model. To speak further about epigenetics, we must examine the Dutch hunger winter that took place from 1944 to 1945. After a railway strike, the German occupation limited rations such that people, including pregnant women in the western region of the Netherlands, including Amsterdam, received as little as 400 to 800 calories per day. The famine affected people of all social classes and was followed by growing prosperity in the post-war period. During the hunger winter, this study, which results were first published in 1976, this provides an almost perfectly designed, although extremely tragic, experiment in the effects of intrauterine deprivation on subsequent adult health. This study has provided crucial support and fundamental insights for the growing field of developmental origins of health and disease. You can see here the young child depicted on this slide. He's 9 years old, and he is very symbolic of what you might have seen during the Dutch hunger winter. He was one of 3 children that survived in his family, and he carried around a spoon with him in the event that any food might become available. We also know, as far as epigenetics are concerned, that Vietnam veterans suggest that symptoms are transmitted to family members, and this could be a result of vicarious trauma. But we must recognize that there is an intergenerational transmission of symptoms of PTSD. This again moves further away from the disease model and begins to recognize the impact of our daily environment on our health. The result is a radically new perspective that we can be active participants in our own well-being. So what makes an event traumatic? How does a traumatic event result in a traumatized person? There are instinctual trauma responses that each individual holds, and we again know that the environment can have a significant impact on one's response. Instinctual trauma responses include the fight, flight, or freeze response that I imagine everyone is quite familiar with, but sometimes we also see dissociation or an altered state. The body does in fact keep the score, and the body holds memories of trauma. Most recently, the Attached Trauma Institute also started to look at this concept of fawning, and what does fawning look like in children who have been faced with adverse childhood experiences, such as traumatic events. We can see some instinctual trauma responses here as well, in that people start to learn how to adapt to survive, that they are seeking approval from others not to rock the boat, they're flattering others, they're unable to describe how they feel, looking for cues from others. So really, when one person responds, you will see a similar response being mirrored. They let other people dictate their behavior. So again, not to disrupt the balance, but they're constantly looking for a state of regulation that they cannot produce on their own without effective coping skills. In this concept of appeasing everyone, that they're checking in with the adults, that they're making sure that they're behaving in a manner that's acceptable, but maybe not necessarily what is true to them as they're developing. So this can very much also be tapped into fight, flight, or freeze response. When we're looking at fawning, which has been overlooked as a trauma response, a child can fawn with adults while fighting with peers. So you might see this type of separate behavior occurring with adults who are authority figures versus peers who are of a certain age group that is similar to the child. We must look at the memory and trauma response. We have explicit or declarative memory, and then we also have implicit memory. And when we look at the hippocampus, it is associated with learning and memory. It chronologically encodes a language and all experiences in that narrative memory. It is true that research has found that based on traumatic events and responses, the hippocampus has in fact been known to shrink. This presents itself as an individual coming into service who truly might not be able to remember a traumatic event. So when we're working with them, we need to keep this in mind. It is the way that the body defends itself from things that they may not be able to handle at that moment in time. Also, we look at implicit memory, which is tied to the amygdala. If you remember, the amygdala is basically the smoke alarm system of the brain, and it's constantly on the lookout for things that might be triggers or stressful events or things that are threatening to us. It helps to protect us from danger and puts our body into survival mode. When trauma is occurring or perceived trauma occurs, the amygdala can stay overactive, which can lead to those feelings of being in a constant state of hyperarousal or being extremely anxious, or feeling threatened, or as if they're in constant danger. There's also research to show that while we know that the hippocampus might shrink, that the amygdala in fact can enlarge with trauma after trauma. To speak a little further about trauma memory, looking at explicit memory, which is conscious, intentional regulation of factual information, previous experiences, and concepts. It breaks down into semantic memory, which is the memory of general knowledge and facts, as well as episodic memory, which is an autobiographical memory of an event or an experience including a who, what, when, where. Implicit memory, on the other hand, is a recollection of acquired and it's used unconsciously, and this can affect thoughts and behaviors. Implicit memory includes procedural memory, which is the memory of how to perform a common task without actually thinking about it. So a good example is knowing how to ride a bike. You ride a bike automatically. However, you don't have to think about making sure that your feet continue to push the pedals and your hands are holding onto the handbrakes. Your body just knows how to do it once you're proficient at riding a bike. Next is emotional memory, and this is the memory of emotions that you felt during an experience. So when you look at these two types of memories, whether it be explicit or implicit, you will clearly see that individuals that have experienced a trauma are engaging in substance use disorders. It'll be like a seesaw effect in terms of this explicit or implicit memory. It will be very unique to each and every individual as to what is presenting more frequently, when and how, and when we look back at our senses, you will be able to see how different sensory experiences will trigger explicit memory or implicit memory effects. So let's take a closer look. When we have memory and action, so continuing with the bike metaphor, somatic memory is when you remember what a bike is. You know what it is when you see it. Episodic memory is that you remember the sights and sounds of how scary it was when you hit a rock and you flipped over on your bike. Procedural memory starts to tap in when you can ride that bicycle automatically without being able to recall exactly how it's done. You may even be able to relate to having ridden your bicycle and gotten to your destination, and whenever you thought back about how you got there, you don't exactly remember because you were very much on autopilot and it's very procedural for you. And lastly, emotional memory. The next time you see your bike, you might be flooded with embarrassment because people saw when you flipped your bike over, which was awkward and a very vulnerable moment for you. So here you can start to see the silos of memory and how they can be very complex and also interact with each other whenever it comes to a traumatic event. As we dive deeper into memory and trauma impacts on memory, I want us to take a look at how trauma can affect the certain silos of memory that we discussed, and also looking at how this can be interconnected. Although you see here the related brain regions, I'm not going to spend a ton of time focusing on how the traumatic events impact particular regions of the brain, but I do think that it's important for our purposes to look at how trauma can affect aspects of the brain and how that might present in counseling. So for instance, when we look at the explicit memory, the somatic memory, trauma can very much prevent information like words and images and sounds from being able to exist in that moment. Here we could see somebody struggling to identify with a bike, although this could be very commonplace in any other day. They may struggle to identify a word to associate with the bike, or images associated with bike sounds, or associated with riding a bike. This could be very frustrating for an individual in counseling, and it's important for us just to be able to take the time with them, to be attentive, to stay present, and to help them engage in that association. And we want to be able to help them to self-regulate and build upon those skills. Trauma can affect episodic memory by shutting down episodic memory and fragmenting the sequence of events. So you might be able to recognize the bike, have language associated with the bike, but maybe your time orientation was off around riding the bike or who exactly was there whenever you fell. When we look at implicit memory and procedural memory, trauma can change patterns of procedural memory. For example, a person might tense up unconsciously. Maybe they alter their posture, which can lead to pain or even numbness. So maybe this is an event where you're asking individual to say a little bit more about their experience, and then you see them physically tensing up in front of you. You may see them becoming uncomfortable. They may be acknowledging pain in certain areas of the body, which may be related to how the body has retained the memory of the traumatic event. Again, we know the body keeps the score. Also, the emotional memory. After a trauma, a person may get triggered and experience painful emotions, often without context. This could be the result of perceived versus real threat. This could be a result of our senses picking up on particular smells or particular things in the environment, a particular feeling, maybe whenever you touch the bike. So we don't necessarily know how our senses are going to impact our brain regions, but what we do know is that when that happens, a person can be extremely triggered, and this can seem completely unrelated to a traumatic event. As we further the conversation, it's important to recognize how our body responds to stress. So when we see our memory coming into play in different aspects of how trauma impacts our memory, it's fairly common that people would experience the fight, flight, or freeze response, and these are completely automatic reactions to stress. When we encounter a threat, whether real or perceived, the brain's fear center, aka the amygdala, lights up. And once it is activated, this area of our brain sends a message to the rest of the body that we are under attack. Our body then starts to mobilize the necessary resources that goes into survival mode so that we are able to survive. At times, people may even experience a panic attack. Sometimes a severe panic attack can cause someone to pass out. And this is the body being able to mobilize those resources to help you survive, to help you shut down so you can regulate your breathing and your heart rate and come back to a baseline regulation. Chronic stress is extremely detrimental to the body. This is very different than normative stress. In fact, normative stress can be empowering in our day-to-day life. It can keep us motivated to meet those deadlines, to be our best self on our very first interview or a first date. But when we have these automatic reactions to stress and it turns into chronic stress, we have this mind, brain, body connection that's very significant, and it can have very detrimental on our lifespan, our health, and our well-being when we are not able to come back to baseline. So let's talk a moment more about real versus perceived stress. A real threat could be a traumatic event or a series of traumatic events and the response that comes from the traumatic event. Let's think about 9/11. For individuals that were there in that moment and had that lived experience, that is very much a traumatic event and very much a real threat to their survival. For an individual perceived threat, somebody was able to survive the 9/11 events, and today they're still having triggers. This could come in terms of loud noises when a car backfires. We see this in our veterans having a response to fireworks on the 4th of July as an example. So they might not be in a real threat situation, but there is a perceived threat because of the body's memory and how the body responds to that. With that, the autonomic nervous system will look to show us how to handle and survive the event. The perceived threat could be a sympathetic response, stimulating that fight, flight, or freeze and giving us a large boost of cortisol. Or, in the other way, this could impact the autonomic nervous system in the parasympathetic portion, in which that would stimulate the feed and breed or the rest and digest. And the parasympathetic nervous system helps to stop that cortisol release, to help people become more relaxed, to help digestion be facilitated. The parasympathetic nervous system stops cortisol release and helps people to become more relaxed. So these two autonomic nervous system responses, the sympathetic and the parasympathetic, are very important to recognize in one's presenting demeanor within a counseling session. If we see that a sympathetic response, someone is having that, they may want to flee the situation, whereas if they are having a parasympathetic response, maybe you start to see them relaxing. Maybe they're using grounding techniques. Maybe they're starting to do some breathing techniques, things that they need to do to regulate and to get a handle on their emotions. So the body can very naturally go into survival mode, and sometimes, especially for those who have experienced trauma, we have to actively work against that to prevent the sympathetic nervous system from automatically taking over. We know that adverse childhood experiences have taught us a lot about how the impact of childhood adversity and how that impacts across one's entire lifespan. We know that individuals that have had traumatic experiences are more likely to be at risk of long-term health, infectious diseases, chronic diseases, and engage in higher, riskier behaviors such as using drugs and alcohol. And they can have long-term impacts on one's educational and occupational status. We know that the ACEs, the Adverse Childhood Experiences Study, is the framework that is very useful. Again, we've spoken about this, yet it does not tell the full story of trauma. It does not take into account the range of emotional and spiritual traumas, which are an outgrowth of consistently denying or repressing the needs of the authentic self. The ACEs assessment surprisingly does not take into consideration our outside environment, the way that society at large can be traumatic. There is not a single question on the ACEs about racism, such as discrimination and abuse, which are obvious forms of racial trauma. It is true that the ACEs study has been extremely impactful. It is true that the ACEs study has helped us to conceptualize adverse childhood experiences and its lasting effects. But I'm challenging us to think deeper and look at how those childhood experiences and the environment and spirituality can definitely impact one's ability to recover and change, or maybe roadblocks to that recovery. As we start to pull all this together, we'll get some final thoughts. We recognize the strong connection between trauma and addiction. For an individual that has experienced trauma and has had adverse experiences, we are more likely to engage in maladaptive coping. This could be a way to help ones regulate their emotions. This could be a way to help them pick themselves up, to help them get themselves to sleep, to help them be productive in daily functioning, or to help them take care of their children. We can see maladaptive coping patterns for people that have experienced trauma and addiction, and they become very much intertwined. Some of the most maladaptive coping that I have seen in the field include this type of people-pleasing that could result in loose boundaries. This might be engaging in drug-abusing subculture or linking up and spending time with high-risk people, places, or things in order to simply have connection. So despite how maladaptive that connection might be, again, we know how important it is for us as human beings to have connection. You can also see some common themes in anger and rage, and we must recognize that anger is a secondary emotion. Often preceding anger is anxiety and fear, so we'll do our work in treatment to help people to self-regulate, to engage in relaxation, and to start to look at those primary emotions of anxiety and fear, and to help them manage it differently. Finally, maladaptive coping can present as a disassociation. This could help put someone into survival mode. The individual is not yet prepared to cope with the trauma, might not have committed to addressing the trauma, to addressing recovery, and dissociation can take many forms for them. This could also be a result of sensory response and the memory starting to show in one's body. Lifestyle choices, we must recognize that all change is loss, even positive change is loss. We must recognize that this idea of just stopping using substances is not sufficient. We must recognize that individuals had a connection to the addiction, and when we remove that connection, people are often feeling very lost. They might be pulling backwards to what may feel very familiar to them. Going back to those high-risk people, places, and things, this is a result of the stages of change being very non-linear in its process. This is also because of the main function of our subconscious mind to keep us safe, and it is threatened by change. And ultimately, people can engage in poor judgment at any point in the recovery process. We do recognize that people can and do recover, and we know that once people have a connection and they have that restorative connection, the ability to decrease maladaptive coping, to decrease harmful life choices, to decrease involvement in high-risk behaviors, and to decrease in poor judgment can absolutely take place. On the flip side of that, you will see people begin to develop new effective coping strategies to combat triggers, to make lifestyle choices that don't feel overwhelming, to engage in behaviors that eliminate risk. And it could very well be harm reduction behaviors, which we've seen be very highly effective in the field versus this idea of being drug-free. We might look at drug-free as being a long-term goal, but the short-term goal is working towards harm reduction. Let's work towards self-regulatory behaviors and improving one's judgment, to engage in behavioral modification, and to support one's recovery. Finally, when we look at trauma, the impact of trauma in the connection of trauma to substance use disorders and mental health, we must recognize people are very resilient. People can demonstrate and build resilience in the face of trauma. Resilience is not, however, innate. It is not a property of childhood. It is influenced primarily by connectedness. So how do we transform into having a choice? How do we transform into restorative connection that will support our recovery efforts, thus building resiliency? I challenge you to think about these questions. I appreciate your time today as we talked about the impact of trauma. Again, as part of a review, we looked at epigenetics. We talked about the trauma response on one's body, specifically memory. We also explored the addiction-trauma connection. I hope that this information has been helpful to you to conceptualize a case of an individual having experienced trauma and engaging in substance use disorders and how this might present. I hope that this provided you with some insights as to how you would approach that and particular interventions that you would use to help an individual engage in behavioral change.